I couldn't believe it. It was stunning. I had thought of myself as a as a health conscious, exercising non-smoker, lifelong non-smoker. So it was stunning to me, and to the point of being disabling to me. I couldn't function. It was as if someone had shocked me.
Like Michael, it was a shock, nothing we expected.
My diagnosis was made in the summer of 2003, and the events leading up to it were that I began experiencing some pain in my back. It occurred while I was playing basketball, but also while I was just doing what I needed to do, resting or activity of one sort or another. And I figured, it was a strained muscle or something like that, but it wouldn't go away. So eventually I had it checked out, and as a precaution, my primary care physician had a chest x-ray done, and he called me up and said, well, did you know that you have something growing in your lung?
I think from the beginning I felt the need to support him and to come alongside him and meet the needs that he was having.
As far as communicating my diagnosis with other people, I did not take responsibility for that. I figured someone else will handle that. My wife Stephanie did a lot of that and began kind of regular updates about my treatments and so on. I think I was too emotionally disabled, really, to think, what is my responsibility in this? What I wanted from other people was not peer group support, because our faith is important to us. What I really wanted was, I suppose, spiritual support and prayer. That's what I asked for, and that was the most important thing to me at that time.
My emotions were all over the place. I didn't feel like I could count on him for support, or should, because he was in such pain himself.
Well, the diagnosis did affect my work profoundly at first, and I have to say I didn't take it very well. There was the trauma of surgery and of the biopsy surgery, and that had a definite effect, as well as starting chemo. So there was trauma to the body, but I think even more significant than that, there was psychological trauma. I was a basket case for months. I hate to think about how long, but I did virtually no work for 3 or 4 months and then gradually eased back into my work life. So it was very, very hard at first.
I think it was probably periods of time, starting maybe just a few weeks after the diagnosis, where I would sense that Michael was able, at that time, was strong enough to be able to hear my heart too. And I think just being with someone for so long before the diagnosis happened, I could sense when it was okay to let down with him. And then of course those times became more and more frequent, and it's not an issue at all now.
My fear level was very high, to the point of perhaps being in denial a little bit. We had a sense that the prognosis was very poor, that the chances of surviving a year or two were, well, that was sort of the typical life expectancy. It was terrible. It was absolutely terrible.
We have 4 daughters. At that time they were ranging in age from 12 to about 23. As a mom, I wanted to protect them from the pain of the diagnosis and the fear. And yet they needed to understand exactly what was happening, and they did from the beginning. We were forthright with them, let them know exactly what was happening, but it was still very difficult.
During that period where I was emotionally disabled, I did cry a lot. In fact, I was pretty sure that I had cried more as a 46-year-old adult man than I had ever as a child. I mean, just in terms of sheer volume of weeping. I think maybe in a typically masculine way, the emotion was more implosive than explosive. And for me, that was the right thing. My conversations with my wife, Stephanie, were very important. A lot of it was dealt with internally, but not really bottled up. I did let it out, but it was in my own room, and I let those emotions go, and that seemed to work for me.
I think there were a few key people in my life that I felt safe with, as far as being able to let down with them and let them know exactly what I was feeling and to cry with them. That was really freeing, to be able to be completely honest and share my fears and the pain that I was feeling. Even now, it comes back to me when I think about it. It was really important to have people in my life who could hear from me and could deal with my emotions and the things that I was dealing with as a spouse.
The course of my treatment has involved many different forms of chemotherapy and pills and so on, both standard treatments and clinical trials.
When we think about personalized medicine, that means a lot of different things, and it's led to improvements in treatment in many ways. One of them could be categorized as sort of our two general types of targeted therapy. One of them blocks the blood vessels that support a cancer, and the other is many different types of medicine that block growth signals towards cancer cells. Now that we have these type of treatments, we're learning better and better how to combine them together or with older medications.
A typical run would be 6 months, a year, maybe a little over a year. I'd be on one drug, something more traditional, then a clinical trial, then something back to more traditional. And I have to say, the sequence of treatments is now something that I'm very comfortable with.
Michael is on a combination of a blood vessel blocking therapy with one of our older chemotherapy drugs, Taxol. And that is the backbone of his treatment. In addition, he has a new anti-blood vessel therapy that we think will help, or we hope will help, make the combination even better. We're very encouraged by how well he's doing. Another concept is combining two or more drugs that are blocking the growth signals. One way we think about that is with EGFR blocking treatments, known as Tarceva or Iressa. Those are the oral drugs, and we know while they are very effective, eventually most patients stop getting a benefit from them. And there are a couple mechanisms by which that happens. And we hope to find, and some evidence is very promising, that if we block some of those resistance mechanisms with other drugs, that we can have a longer benefit and maybe a more substantial benefit even.
If a doctor says to me, look, this treatment isn't working for you anymore, we have to try something else, it is a good thing. It's a positive thing. I have a lot of respect both for the old line traditional treatments and for the emerging new, technically exciting treatments that come out of research studies, genetic studies, and so on. I think the combination is very exciting. I feel quite confident that I'm in a much better position now, 8 years into it, than I was at the very beginning when the treatment options were more limited. It's a much better time for lung cancer now than it was then. And with more discoveries and more products, more pharmaceuticals coming online all the time.
As Michael described to you, he really has lived through this. He has been on many different chemotherapies, been on 2 clinical trials with really dramatic benefit, and so we hope to see that happen more and more for patients.
I'm definitely a fan of clinical trials. When I hear somebody has a cancer diagnosis, I encourage them to listen to their doctor, to not be afraid of kind of the standard chemo drugs, because, well, the way I expressed it to a friend recently is chemo is your friend, and if that's what your doctor prescribes to you, and that's good stuff.
Clinical trials were presented to Michael as an option maybe a year or 2 into his treatment. And the standard chemotherapies had worked for a while, and up to that point had been effective. But we got to a point where they weren't as effective anymore, and the next logical step at the treatment center where Michael was looking into clinical trials and new things that were coming down the line that provided hope for Michael in his battle with cancer.
When we think about some of our targeted drugs, up till this point, we know that they often work best when we identify the abnormality in the cell that's driving the cancer and we block that abnormality. However, many of the cancers that we see don't have a single driving mutation, for example. And so then we think, and we have some evidence to show, that if we block more than one growth signal system at once, that we can get an added benefit. One of those combinations may, for example, block EGFR, the epidermal growth factor, with another pathway, for example, c-MET. We know that there is what we call crosstalk between these signaling systems, and you could imagine if you block one, the cancer cell may develop a backup system. If you block both, you might get a significant benefit.
I have regular scans. The scans are evaluated, and we take the treatment really week by week, month by month. I never really know what the next course of treatment is going to be or when it's going to start. That creates some anxiety. That's stressful, but it's a reality, and I deal with it.
Right now, and in the past few years, I think we have, and I have felt that we're at a place where there is hope. There are new treatments coming down the line. We hear about them from Michael's oncologists and read about them. Never could have imagined that 8 years out and 2 weddings and several grandchildren out that he would still be here. It's due in large part to clinical trials. And we're eager to keep those as part of Michael's treatment and look forward to what else may be out there for him so he can continue in this life with us.
Well, one of the trends in treatment is how do we combine the drugs that we have at this point. One of the ways that we move cancer therapy forward is taking drugs that we've found to be effective against metastatic cancer and trying to learn how to use that to prevent recurrent cancer after surgery. Those are the clear trends going forward. There are also, we have the identification of other tumor characteristics that we might be able to exploit for treatment. There are some exciting developments in squamous cell treatment, finally, after many years of not as much progress in that field. Some of those drugs would include new formulations of older chemotherapy drugs that may target the chemotherapy to the cancer cells. Other areas of active research are some immunotherapies. There is at least early promising data for vaccine therapies after surgery, and of course we have to wait and see what the larger studies show, but there's a lot of interest in those fields.
I think the experience of having cancer has had effects on me that perhaps don't follow a script. Some people think, oh, you're more attentive to sensory experience around you, you smell the roses, you're in the here and now. But that script really didn't work for me. I actually became more professionally ambitious. I set more long-term goals. I started looking out to the future. So I would say to other cancer patients, you don't have to follow the expectations that other people have for you.
There are more patients that are living more than 5 or even longer years. I think that puts their disease into a different light. It becomes more of a chronic illness, and we can then think about it in some ways more like diabetes or heart disease, where a patient has to be aware of the disease, has to fit it into their life and the treatment.
Certainly it's given me a sense of the preciousness of life, and I am extremely grateful. I think that's my dominant emotion, is gratitude, thankfulness for being alive, for being, and not only just alive, but for being very much engaged in life so many years out. I'm working harder than ever. I'm writing my third book. I'm very involved in recreational activities, perhaps excessively so, but life is very, very full. And it's wonderful to not think about cancer as defining my life, as being my primary reality, to acknowledge that cancer is a fact, it continues, but it doesn't dominate the way it used to. And that's a huge, huge blessing for me.